Welcome everyone to this lunchtime symposium sponsored by Philips. It's on advanced imaging in structural heart intervention. I'm Sushil Kadali and joined by excellent faculty of Matt Price, Gagan Singh, Martin Swans, Roberto Corti, and Patrick Biaggi. So we're going to go through several different concepts today. The first is something that's going to be clinically applicable very soon with the upcoming approval of the VeriSight, availability of the VeriSight 3D ICE probe in Europe. We want to try to show some examples of how this probe is different and how to characterize and how to use it in clinical practice in both left atrial appendage, mitral, tricuspid procedures. The second objective of the session is to really learn how AI-enabled device detection technology with pulsar technology and DeviceGuide is going to really have the potential to streamline procedures going forward in the future. So I'm going to start this session off. These are my disclosures. So we talk about the structural heart revolution a lot, and it's over the last 2 decades. Transcatheter therapies have really evolved, and it's been disruptive technology, and a lot of new patients are getting treated with new therapies that otherwise wouldn't have had options or had higher risk options, and that includes both aortic, mitral, and now tricuspid. But that really has been enabled by the imaging revolution. A lot of what we're able to do, it relies so heavily on imaging in the procedure room, whether by fluoro or echo or intracardiac echo, and that's really changed the game. A lot of people remember the first MitraClip was done in 2003 with the 2D imaging, and it's like this. And we have 2D imaging is challenging and it's great, but it has a lot of limitations. And when these initial MitraClip procedures for the first decade remained very challenging because you need to have high quality imaging, you need to understand 3D space, you need to be able to navigate in 3D space but with 2D imaging. And that posed a lot of challenges and limited the broad applicability of these technologies. And part of imaging revolution is to enable these technologies to be distributed broadly, sort of to democratize the procedure. So whether someone does 10 procedures or 200, that they can get the quality imaging necessary. And that includes things that we're going to talk about today, including 3D echo, the DeviceGuide, fusion technologies. Really, the goal of all these technologies is to better enable treatment options and across all centers. But there's all this concern and thought about artificial intelligence, and people worry about AI, and AI is such a broad term. But in what we're talking about here, the goal of AI is to really optimize results, improve procedural efficiency, and democratize procedures. Because you need to enable everyone in the world to be able to do the procedures as simply and as safely as possible. And AI sort of gives us that ability and freedom. And we're going to see a couple things later today. The first is DeviceGuide, which sort of fuses the fluoro with the echo and allows people to navigate more clearly and more safely on echo. And then, but beyond that, we're also going to talk a lot about the 3D ICE catheter and its availability. It's really sort of changing the game and giving options and to improve procedural efficiency as well as safety. So we already talked about the panel, but just in a few minutes, just want to talk about the ICE system. So this is the VeriSight 3D ICE catheter. It's a 9 French device. There are the 2 steering wheels and the clutch knob which holds the curves. This is a single-use disposable unit. It connects to the Philips machine with a reusable cable. There's no bag you need to put on it because this part just comes off the field, so no issues with sterility. But just to understand how it differentiates from 2D ICE, 2D ICE is, again, 64 discrete elements. It's 9 French, but 2D only. With the VeriSight 3D ICE probe, you see here it's 840 discrete elements, phase array. It's still 9 French, and it has a 90 by 90 3D field of view. And it provides you the ability to do X-plane imaging like we have with our 3D probes, and you get 2 full resolution planes simultaneously. But there are some limitations, and it's important to understand the differences. When you talk about TEE, it's a square phased array. Here, it's not. And so, in the 0 degree, it's not horizontal, it's vertical along the length of the rectangle, and the 90 is opposite. And that has some important things that we have to keep in mind that both Matt and Gagan are going to show in their clinical cases. It limits, so the 90-degree field is not going to have the best quality imaging. So when you're using the probe, you have to keep that in mind. You know, at 0 degrees is obviously the largest aperture, and you have the best quality imaging. But as you get closer to 90, that goes off. And so that comes relevant when you're using X-plane. So if you take an X-plane at 0 and you get the 90-degree view, your resolution's not going to be good. So sometimes what we often do is rotate to either -30 or -45, get the view that we want, and then X-plane off that. And that's because that will maintain your quality of your resolution. And this is just an example where you see here, this is the primary view, and the X-plane at 90, you see it's much more coarse and the resolution's not as good. And so, you know, but if you do this at -45, your X-plane resolution is better. So oftentimes, you know, you have to fiddle around, and we might find the primary view in -45, so that we can get a better resolution on our 90-degree X-plane. And these are some just technical things that Matt and Gagan are sort of going to highlight in their clinical cases. But one thing I want to say is that really, you know, these probes are great. They're going to help us, and we're going to learn how to use them better going forward. You know, all of our MitraClips we do asleep, but there are scenarios and cases where we can't. And this is just an example. A patient with a severe hiatal hernia also has issues, couldn't go to sleep, that we had to do a mitral TEER awake with ice. And you see the quality of imaging you can get. We're not at a point where we're going to routinely do that as an awake procedure, but you can also see where this technology can get there. And I think those are important things to keep in mind. You see great quality imaging of the leaflets. So these therapies have revolutionized the treatment of structural heart disease. And this progress, and more importantly, the dispersion of these therapies, would not have been possible without advancements in imaging. And it's really going to help democratize the procedures across the world. And we're sort of at the beginning of this imaging revolution, and things are going to change. And we're just going to give you a taste of that here today. So I think to get started, Matt, you're going to come up and talk about the use of the ICE probe in left atrial appendage occlusion. Thank you.
Great. Well, thank you for the opportunity to talk about my experience with 3D ICE-guided left atrial appendage occlusion, which is now my default approach to closing the appendage. So these are my conflicts of interest. So what are some direct impacts you can see when you transition to 3D ICE guidance for left atrial appendage occlusion? These are just some of them. So the key things, because you don't have TE or need deep sedation, there's no anesthesiologist, you're using moderate sedation, and there's no TE or general anesthesia. And some things that I've observed is I've been able to stagger cases in multiple rooms, which improves scheduling flexibility. You get more cases per day, more monthly volumes, PCI-like turnarounds, less intensive nursing and recovery, less complications, both nuisance complications, but as well as major complications because you're not intubating the stomach or the deep esophagus. You have fewer physicians are required in the room. And in turn, there's a reduced burden on the hospital and improved patient satisfaction. So all these things really change the way that both the physicians and the hospital approach left atrial appendage occlusion, and also changes the patient experience. Another thing to think about is as the large randomized trials of Catalyst and Champion AF report in the coming year or two, is there may be a broad expansion in the indication for left atrial appendage closure, which will increase the burden on hospital infrastructure and medical personnel if LAO becomes a first-line therapy for patients with atrial fibrillation at risk for stroke. So that we need to make it possible that the throughput of our patients is smoother and quicker, and 3D ICE is one contributing factor which will, I believe, allow us to do this. So let's talk about how one goes about a 3D ICE-guided procedure. So the goals really, big top-line goals are to have the same robust outcomes as TE guidance. You want to minimize catheter manipulation of the ICE probe, and you want to maximize procedural efficiency. So this is just on the list, bullet points of what we do, which you would do really in a TE-guided procedure, and it's really agnostic to device. So I'll show a Watchman case, but that's the most commonly used device in the United States, but We've used it for Amulet, and you can use it for the various devices available across the world. So this is my workflow. When I see the patient and speak to them about LAO and I feel they're a candidate, I will then do baseline or pre-procedural imaging, which I think in the case of 3D ICE does enhance procedural efficiency, because as long as you do the CT scan close behind the procedure, you can rule out LA thrombus. You can size the appendage. You don't have to do those things intensely at the time of the procedure. And then you can go ahead and perform the LAO. So let's walk through an actual procedure. And we will recapitulate the very things we do with a TE guided procedure. There are no shortcuts, but we'll show that with ICE, we can do the same thing, if not better. So the first thing one wants to do is make sure there is no baseline effusion. If there is, to document it. So there are some maneuvers you can do by moving the device into the right atrium at the correct angle, and you have a beautiful baseline view of the 4 chambers of the heart here. And these are all pictures from my lab. These are not just textbook examples. Then you're going to do your transeptal puncture, and you will get the same types of images that you would get with an X-plane TE, except it's a little bit different because the image is flipped. So the left atrium is on the bottom and the right atrium is on the top. Here, as Sushil mentioned, there's 2 angles, 0 to 90, and I drive on 0 because that's like when you drive your car, you're looking straight ahead rather than looking to your left as you drive forward. Here, with a transeptal puncture, the short axis view of the aorta is about 60 degrees away from the bicaval view. So you can just drive in 0 and go to 60, and you see here, just like a TE, I'm doing a low mid puncture, or an inferior and mid stick. Now, you're responsible, you can't blame anyone else other than the person driving the ICE catheter to find the tenting of the septum. So it does add a little procedure complexity. We'll talk about that at the end. So sometimes you may struggle to find the tenting of the septum. Very easy to use fluoroscopy. And the key for all of this guidance is to ensure by fluoroscopy that the imaging plane of the VeriSight 3D ICE catheter is pointed towards the region of interest. So here, if you lose your transeptal sheath, make sure that the imaging plane of the ICE catheter is at the level of the transeptal sheath. And here, this is a perfect view of where you will see your tenting. So then you have to get the ICE catheter into the left atrium. And this can be, at first may appear challenging, but once you get the hang of it, it's very quick. First, once you cross with your transeptal wire, you then dilate the septostomy. You can use your LAO delivery sheath to go back and forth and dilate the septum. And then what you're going to do is I use fluoro. You can also use the actual image on ICE, but I use fluoro to, in the LAO projection, you're going to align the ICE catheter with the wire. And then you'll go back and forth on LAO and RAO as you manipulate the catheter. So in this example, I put on some anterior flex, and then I go RAO. So this is anterior posterior, and I clock the catheter slightly. And I go back to LAO, and I'm just following the wire, and you're across in the left atrium. So once you're in the left atrium, that's where all the action is going to be. So you can do a baseline LA assessment with your 3D ICE catheter. I generally forego this because I've already done the CT imaging, so I know already the size of the device that I'm going to use. But you can do this if you don't have baseline imaging. Just like TE, you can do multiplanar reconstruction. And this is just a great example. The latest generation software on the Philips machine is amazing. You get great resolution, and it's even improved that 90-degree resolution that we were concerned about previously. So this is just a case where you can measure the baseline images. Again, my manipulation of the ICE catheter in the LA is looking up the axis, coaxial with the left atrial appendage. And once you have your pigtail in the LA, you have a target to image for. You can also, if you like, measure the LAA baseline dimensions by going through the quadrants of the LA. So how I do this is I find the long axis of the LAA in the 0 degrees, and then in the X-plane, you can just rotate through all the quadrants. That would be 45 degrees, negative 45 degrees, and 90 degrees. There are also hotkeys if you want to go 0 and 90 and 45, negative 45. Now, 90 degrees, yes, you have less resolution, but certainly for an LAA procedure or LAO procedure, usually the 90-degree view is sufficient enough to make decisions. All right, so now I've implanted my device. I've used a 31 millimeter Watchman Flex. Again, you see my angle of my ICE catheter looking straight up. In this situation, it's a superiorly directed left atrial appendage. So my ICE catheter is retroflexed above the mitral valve looking up. And now we're going to do the same thing we would do for a TE-guided Watchman Flex procedure. I will look at my device position, look for PDL, a peri-device leak, and look for compression. So here, again, my technique is just to find the device. You're going to look for the threaded insert, so you know you have the entire long axis of the device in the 0 degrees. And then we're going to roll through, using the X-plane, the 4 quadrants of the LAA and make sure that there are no peri-device leaks and that I like the position. So just like for the Watchman device with TE, where you get your 0, 45, 90, 135 degree views, those are just the 4 quadrants in space. So with 3D ICE, you just make sure you see all 4 quadrants. For an amulet device, it's very straightforward. You look at the position of the lobe and its relationship to the circumflex in the various quadrants. So then you do your compression assessment, just like TE. Now what I've done is, when I went through those 4 quadrants, I captured color and I captured a clip without color. And then you can go back and freeze those captured images and do your measurements. And here, I've measured all 4 quadrants, and my compression is excellent. You can also use multiplanar reconstruction and measure the diameter of the device or the compression of the device in that way. And then you release the device, and I just like to get some final images, just so you know what it looked like when you leave the room. And again, if you look at the image here, my ICE catheter is looking straight up at the face of the device. And in my 0 degree, I see the threaded insert, so I know I'm slicing down the middle of the device. So my diameters are correct. I've just gone through the 4 quadrants and recorded them, and I have a beautiful position of this device. And then when we're done, you can quickly do the things that an echocardiographer would do, or at least tell me that I need to look at, and that's to make sure that you have left to right flow across your interatrial septal defect. You also want to look for a post-implant effusion. You can either just from the left atrium look down on the mitral valve, something that Goggin will talk a lot about when he talks about ICE-guided mitral TEER. Or you can do that technique from the right atrium where you see the 4-chamber, and again, there's no effusion. So what about increased complexity? Because now if you're doing 3D ICE guidance and you don't have a partner doing the imaging for you, you're doing both the implant and the imaging. So there is data from the NCDR, which is the U.S. National Database for left atrial appendage occlusion, and the investigators looked at about 35,000 patients and stratified those cases by ICE guidance versus TE guidance. You can see the rate of ICE guidance is fairly low, and this is pre-3D imaging. So this is predominantly 2D ICE. And what you see is the patients who underwent ICE-guided LAO had longer procedure times by about 4 minutes and slightly more contrast. So longer procedures, a bit more contrast. Now, if you look at procedure time and contrast use as a function of operator experience, it drops quite substantially. So experienced operators had quite short times, and the contrast use went down. What this tells me is that an approach where you say, well, I'm only going to use 3D ICE when I really need it, when my patient doesn't have an esophagus, or when the patient has varices or what have you, that's not going to be helpful for you or your patients, particularly for flow in your cath lab. So it needs to be something that you do routinely, and you will get good at it and improve procedural efficiency. So here are my key takeaways. Number 1, 3D ICE will be important in improving patient throughput, particularly as the number of LA closure procedures increase potentially dramatically if it becomes an alternative frontline therapy for our patients with atrial fibrillation who are at high risk, who are at risk for stroke. Pre-procedural imaging, such as CT, greatly improves procedural workflow. The technical key is find the position of the ICE catheter that directs the imaging volume towards the face of the device, and your life will be very easy. And finally, the goals of all of this are light and moderate sedation. So you can talk to the patient on the table when you're done. Minimal physician staffing, rapid room turnaround, same-day discharge, and above all, happy patients and staff. Thank you very much.
Thanks, Matt. So we have some time for questions if people in the audience have questions or comments. So
There's one from the audience.
oh yeah, perfect.
Yeah, I guess, so Matthew, somebody asked, could I use 2D ICE to guide left atrial appendage closure?
Well, certainly you can. The question is it a good option? So one of the challenges of 2D ICE, well, stepping back, the goal for guidance of an LAO is really to look at the various quadrants of the device and make sure you don't have a peri-device leak and you have appropriate compressions. The challenge with 2D ICE is you need to do a lot of manipulations of that catheter to find those quadrants, and often people are just settling for 2 quadrants and maybe 3 on a good day. Whereas with VeriSight 3D ICE, you can plant the catheter in the appropriate position of the left atrium and get all the quadrants. So that's the advantage.
I would argue that you probably shouldn't do it with 2D ICE. I think a lot of device leaks are going to be missed. I mean, you can do it fluoroscopically, but yeah, I think there's risks, and you might. But what is the learning curve? So what would you say is, and does it transfer if you're doing TEER procedures, LAO, other procedures with ICE? What would you say is a reasonable learning curve to get off the steep number of cases, get off the steep portion?
Well, it would depend on your baseline ICE experience. So 2D ICE experience does translate to 3D. So if you're doing PFO closures and ASD closures by ICE, it's a much quicker learning curve. I would say 10 cases and you're really comfortable. Gagan, would you agree with me on that?
Yeah, we actually looked at our own internal LAO series with 3D ICE of approximately 150 patients, and we saw time to cross, because that's the most kind of newest step of the procedure for most patients. Going from right atrium to the left atrium, we saw a stepwise decline where it's almost consistently below 60 seconds now, and this is from 3 operators, and it really took that first 10 to 15 cases to see dramatic decreases in that time. And that's just for that part. So certainly there's other elements as well.
But I would say, I think the more important factor is your experience in an LAO closure, is that you are adding an element of complexity. In the end, it's going to make things quick, but you don't want to be learning how to do an LAO and learning how to do 3D ICE. That's my one.
And I would just add one more thing about 2D versus 3D ICE, Shil, is that there is internal data that both the major manufacturers have that there's increased risk of pericardial effusion with the 2D ICE catheter, and I think that's may reflect the increased manipulation that's needed.
Yeah, I know. I think that's a great point. So I would sort of caution against 2D ICE. In interest of time, we do have to move on. So Dr. Gagan Singh is going to talk about the role of ICE for both mitral and tricuspid TEER.
So just a quick update. I'm actually just going to focus on tricuspid TEER because Martin is actually going to talk about the role for 3D ICE in mitral TEER itself. So, if you think about the indicators of procedural success for tricuspid TEER, just for a show of hands, how many people in the room do tricuspid TEER here? So, fair number. And so tricuspid TEER is important, and the goal of the tricuspid procedure is to actually bring the patient in and do the tricuspid clip and put on 1 or 2 implants, whether it's Pascal or whether it's TriClip, and you want to put a TEER device on, and then patient should leave with 2+ or less tricuspid regurgitation to derive the benefit. Now, there's a lot of scoring algorithms out there that give you an idea of what your chances of procedural success are going to be. So, and this is not rocket science. We kind of all know this clinically. If you got AS gaps that are small, if your jet location is predominantly more aortic or anteroseptal, if you have good imaging quality, not a good imager, but imaging quality, and then of course, depending on what your chordal density is, and then finally what the morphology of the color looks like. But what I would disagree with this scoring system is that it's all weighted proportionately, like it's all 1-to-1 weight. Where I think that if you can have all of these other straightforward parameters, but if you have bad imaging windows, that's going to make for a very challenging procedure. So I think that these scoring systems are good, but an tough imaging window for the tricuspid valve is incredibly common, and it can take a very simple procedure and turn it to a very complex procedure. So do you even need 3D ICE for transcatheter tricuspid edge-to-edge repair? And I think for a case like this, maybe not. This is a case where an imager brings their 3D ICE catheter in and it's positioned behind the right atrium, and you're able to get that. And I'm not an imager, but I'm told that as you advance into the mid-esophagus and you put a little right flex on, and Martin, correct me if I'm saying anything incorrectly, because I, again, in full disclosure, I'm not an imager. If you can get behind the right atrium like this, you don't need adjunctive imaging to help complete a TriClip or TEER procedure. But then you walk in and you see a case like this. Now, all of a sudden, the imager has challenges to getting behind the right atrium, and you have challenges looking at a really good transgastric view on the right. And I can guarantee you that once the TEER system gets in to the right atrium, the imaging is going to get even harder. And so for reasons like this, 3D ICE can be powerful to help you complete the procedure successfully, more efficiently, and with better outcomes. And so in our experience, we use 3D ICE for every case for the first 5 to 10 cases. In our current experience, we don't use it for every case. Patient gets intubated, transesophageal echo probe goes down. I generally will have a secondary access site where intraprocedurally, if I have challenges with imaging quality or imaging assessment of leaflet insertion, then I'll bring the 3D ICE catheter in. And this is anecdotal data. This is not rigorous randomized controlled data. The US experience is anywhere from the folks that are like, I never need it, I never use it, to people who use it all the time. And then there's everybody else in between. So I think most of us here on the panel, I'd probably say we're somewhere in between. And again, I think as you start using it more and more, you'll see where it fits into your own practice. So the current presentation will not go over the omniplane terminology, the knobology, and maneuvering. Very briefly, I'll introduce this concept of 3D navigation. You saw beautifully Matthew show 0, 45 plus, negative 45. This concept of 3D navigation takes the guesswork out of it. It tells you immediately what angle you need to go to or how you need to maneuver your ICE catheter so you can see the TEER implant arms. And to do tricuspid TEER efficiently, you need to understand 3D navigation. So this is what a typical workflow in a tricuspid TEER looks like. So you go to the mid-esophagus, you establish your trajectory, you do your alignment, you advance into the right ventricle. We then generally go into the transgastric position, and then we'll confirm our alignment because it's hard to confirm 3D alignment with the mid-esophagus. You can use live 3D MPR, but it can be misleading because you're not directly behind the right atrium or in front of the tricuspid valve most of the time. You can perform a grasp, and then you kind of bring out your grasping toolbox. This is a slide that was created by Dr. Idris Aman, who's our director of Echo Lab at UC Davis in Sacramento. And so these are all the potential options you have in your toolbox to assess leaflet insertion. I can tell you that over the years of doing TriClip procedures and learning from our colleagues here in the EU, we generally start off in the transgastric. We'll use maybe transgastric MPR. We'll use mid-esophageal MPR. And then we pretty much don't do a dedicated long axis view in the mid-esophagus. We don't do an X-plane view to look at grasps because it can be misleading. You can't maintain your alignment. You can't maintain your trajectory in a lot of those cases. So the problem is that if you have difficulty establishing your leaflet insertion, your grasp in the mid-esophagus, then what do? You go to the stomach. You go to the stomach, and if you still have challenges assessing your grasp or leaflet insertion, then what do? You go back to the mid-esophagus. And then if you still have challenges, what do? You go back to the stomach. And this is the definition of insanity, right? Is doing the same thing over and over again and expecting a different outcome. So something has to change here so you can break this vicious cycle. And oh, by the way, imagers tell me all the time, this is how patients get gastric injury. This is how you get esophageal tears, and these are catastrophic complications. So if you have adequate transesophageal echo windows, all right, so if everything looks good like that first example I showed you, you start off in the mid-esophagus, you go to the stomach, you come back up to the mid-esophagus, and you deploy. Great, you're done. Now, what if you don't have adequate transesophageal echo windows? And so this is the workflow that we generally use. We'll start off in the mid-esophagus, we'll go to the stomach, and if there's any questions about grasp or leaflet insertion, like I said, I already have secondary venous access. We'll go ahead and put our 9 French catheter up. With the Phillips system, it's plug and play. It's literally, we plug it in and you press one button and you see the TE images. You press another button, 3D ICE images show up. You press another button, TE images show up. Press another button, 3D ICE images comes up. So it's very easy, it's very facile. They come back and forth, and that's where that double-sided arrow comes in. So you can do your alignment, and then you can build your 3D ICE 3D navigation map, which I'll talk about, and do your grafts, do your leaflet insertion, and once you're happy, you kind of move on and do your deployment. Now, there are folks out there that do 100% 3D ICE, and the ones that do 100% 3D ICE, this is their pathway, which is they'll just do their trajectory, they'll do their alignment, they advance into the RV, the TE probe goes into the stomach, and it stays there. They'll just confirm their alignment because that is the gold standard for alignment confirmation, and then they'll build their 3D ICE, they'll grasp, do leaflet insertion, come back to the mid-esophagus, and deploy the valve. So for them, this is their efficiency mode, to use it for every single case. So again, your toolbox, your grasping toolbox at our center is we'll start off in the stomach, we'll maybe do an NPR from there, we'll do transesophageal echo, NPR, and then finally we use 3D ICE to assess leaflet insertion. And here are examples of cases where, you have it all aligned. Apologies, keeps moving on for me, I don't know why, but what you're starting to see here is you're starting to see the TEER implant, you're starting to see the two leaflets and everything coming together. So very briefly, I'm going to talk about 3D navigation. This has taken us months to comprehend. The first time you hear this concept, it won't make any sense, I promise you. It didn't make any sense to any of us. Once you start thinking about it more and more, it starts to make sense. And there are some resources now available to have you understand it. So you have a TriClip device in place. You've gone to transgastric, you've confirmed your alignment, but you cannot see the leaflets. You can't see leaflet insertion. So what do? The concept of 3D navigation is you bring your ICE catheter in and you build this 3D navigation map, which is you see the 3D en face. There's a very typical 3D en face. The aorta is down here at 5 o'clock. The IVC is up here. And by transgastric, we are really happy with the way our alignment is. But right now, you have to try to figure out what omniplane am I going to go to on the 3D ICE catheter to see the arms. So just for visualization, I'm going to kind of annotate some things here. Your green box here represents negative 45. Your red box here represents positive 45. If you put a line right through the middle, that represents 0. So this immediately tells me that the omniplane needs to be increased from 45 to maybe 50 or 55 to be able to see my arms. So that's the concept of 3D navigation. It's simple. You're going to use the 3D image, you're going to use the two planes, and just figure out if you need to increase or decrease your omniplane to see the arms directly. There's another maneuver you could do. Say, if, for example, as Shashil talked about, so what if your inflow view is exactly at 0? If your inflow view is at 0, your grasping view technically is going to be at 90, and the resolution goes down at 90. So you can actually move and manipulate the catheter. This is a little bit more complicated and certainly not enough time to go through that. There is also this concept of mode 1 where you can manipulate the ICE catheter so the arms and the leaflets always fall on plus 45 where your visualization is better. So again, very briefly, 3D navigation concept. Here's a case in a patient without transgastric windows. So we bring the 3D ICE catheter in, or bring the device in, and now we've done transgastric alignment. Now we bring it into the ventricle. And no matter what we do, and again, this patient does not have transgastric windows, but we have very high quality NPR. And as we do very high quality NPR, no matter multiple attempts of trying to engage both the septal and the anterior leaflet, we're unable to do so. So again, what this does is allows us to very rapidly use 3D ICE, use 3D navigation. And in this particular case, it turned out to be an omniplane of 50, and we just weren't deep enough. The septal leaflet was so long, we couldn't visualize it on 3D NPR. We just needed to advance it in a little bit deeper. As we advanced it a little bit deeper, we came back and we engaged both the leaflets, the grippers were dropped, and then the arms were closed, and we had adequate leaflet insertion. And again, this is a patient that did not have adequate transgastric window. So this is the step-by-step 3D ICE procedure with tricuspid TEER. This is the Sky ebook. It's available to everybody. Dr. Price will pay for it for you. But no, I kid, it's free. But it's available for free for everyone to use. And it goes through every single, Dr. Price is one of the co-authors of this ebook as well. And it really has a lot of great information on not just the tricuspid TEER procedure, but also how to use 3D ICE for every step of the procedure, and particularly 3D navigation. So I'll close with this, which is, I think if you're going to incorporate 3D ICE into your tricuspid TEER practice, you need to practice it as a group, as a team, but you need to do it in places where you have good mid-esophageal, deep esophageal windows and transgastric windows, and you need to adjudicate for yourself how you're going to apply this therapy for your day in, day out practice. The reality is that most of the patients that we care of fall in these three columns. But that is not the first time you want to take out your 3D ICE catheter. You really want to practice here and then use them for the bulk of the patients that come there. So, again, thank you for your time.
I think we're running a little behind. Is there any questions from the audience if we?
There's only one question, actually. Who's manipulating the ICE catheter? Is the cardiologist or the echo specialist is the question?
Kagan?
Yeah, interventionists, we're very, what's the word I'm looking for here? We're very territorial about our space. We don't like other people next to us as we're doing procedures. And so there's really not enough real estate to have the TriClip implant and the 3D ICE catheter. And so instead what happens is the 3D ICE catheter sits right in front of you, you manipulate, you put it into position, and then the beauty of what Matthew was talking about earlier, the rest of the control is done on the console. So your echocardiologist is changing the omniplanes and moving around and doing live NPR while you have your hands on the device. There are groups, I saw Stefan here earlier. Stefan has, I think, led the way, and he's done a lot of work with 3D ICE being inserted through the IJ. And it gets inserted through the IJ, not the echocardiologist controls the 3D ICE and also the console. So I think there's a lot of different ways of doing it, but for the most part, it's usually subtle manipulations, and then you do the rest on the console.
Yeah, I think that's where the majority do, and I think you sort of get the probe, put a bunch of wet towels, and hold the probe in position so it doesn't move. I think we have to move on, but I think the shadowing issue that you raised, in TEE, do you want to comment 30 seconds because we're already behind, but the impact of the guide manipulation, because you're in congested real estate with the ICE catheter and the guide as well. Can you give sort of a brief sort of thought?
Yeah, so this whole 3D nav, so what happens is if your 3D ICE catheter is sitting directly above the clip delivery system, often you can see the edges of the arms, but then you can't see right down the center. So what you can really easily do in that case, you can advance it a little bit more forward, and then you can use this other, and we don't have time to get into it, something called the concept of elevation tilt. So right now, if you have an ICE catheter, a 2D ICE catheter, if you want to look over there, you're going to manually clockwise rotate your ICE catheter. If you want to look over there, you're going to manually counterclockwise rotate your ICE catheter. With this concept of elevation tilt, you just advance your catheter a little bit more forward, and you use elevation tilt where digitally it will look back at the arms. And that's how you can get past the shadowing.
Great. All right, great. So thank you so much. We're going to move on to our next speaker. Dr. Corti is going to talk about introduction of AI-enabled device detection technology and clinical experience in mitral TEER.
So, ladies and gentlemen, it's really an honor for me to introduce you something that for me is really eye-opening, a new technology based on AI. First of all, it's not yet CE marked approved, and it's working with Pascal in TR only. So the big question is, do you really need an imaging technology? And honestly, despite increasing experience, we are still facing the same challenge in structural valve intervention, and you saw some of them today. So I think in the transcatheter mitral valve intervention depend really in precise puncture at the septal and then perpendicularity to the mitral valve. And this is an aspect that we stress out during the last years, but actually sometimes we tend to forget. And so I think advanced technology should help us to facilitate a complex intervention and highlight this kind of aspect. Something that we have to realize when we are going down to the mitral valve and we look at the beginning at the alignment is that each small manipulation of the catheter will completely change the alignment of the device on the mitral valve. So if you look at the alignment at the beginning of the procedure and then manipulate on the mitral valve, over the mitral valve, or even worse, under the mitral valve, before grasping it, you will change completely your alignment of the catheter, potentially leading to a distortion of the anatomy. So the new technology based in 3D echocardiography, something similar to what we had at the beginning with conventional fusion imaging, where an algorithm detects the TE probe on the X-ray and then allow to reconstruct your imaging, your TE imaging live in the screen of the X-ray. Now AI allow to detect not only your TE probe, but also the device during the whole procedure. And I will emphasize what are the typical features. You see here the device, which is highlighted blue in this case, it shows you this line, the alignment to the tip of the ventricle. You see here the alignment through the valve. So, as I say, it's based on the NPR imaging view, and in the past few years, we were using mainly NPR to try to optimize our alignment to the valve, but it had this additional featuring of having the alignment lines, so lines that show you during the whole procedure where is align your catheter to the tip of the device. It recognizes the device, so you have information on the rotation of the device and the valve, and in addition provides you an image plan exactly at the level of the device. And I will show you what are the advantages. An additional feature is that you can center the whole system directly in the device. So there are just few steps, but it changed completely the way we are working. The few steps are we start to think at the beginning of the procedure. So the heart team approach starts at the beginning of the procedure. We discuss how we want to have, where we want to have the implant, what kind of trajectory we would like to have at the end, at which one orientation. So the first step is defining where we want to implant the device, and of course is where we have the regurgitant area. So this is our target. Then the second step, and this is still discussed at the beginning, is defining the trajectory. So the interventional is discussed with the echo guy, which kind of trajectory we want to achieve if we want to place our device in this orientation. So the goal is to define at the beginning what we want to achieve, and then you just follow. Once we advance the catheter in the left atrium, as soon as the AI recognize your implant, it turns blue, and it shows you the predefined alignment lines. So what we would like to achieve, the actual alignment lines. So the way where is aligned the catheter are present. You see you have to add flex to go down to the mitral valve, but also it shows you exactly the image at the level of the device. So you don't, for the first time, we can do a procedure with a no-touch technique, without touching the posterior leaflet, the posterior wall of the left atrium. So you go down, and this is everything, of course, live. You go down to the mitral valve. You try to approach more and more your optimal alignment, always looking at it, and looking at your target. And once you are at the target, now you can control your orientation. And this is how it works. You have your orientation, you can control, you have the image exactly at the level of the arms, so exactly at the level of the implants. It means that you see always both arms, not just the anterior one and the posterior is coming in and out from the image. So both arms of the implant are in, very stable. It doesn't depend in deteriorates with cardiac movement or respiration movement, and you have a very, very controlled, grasping situation. In cross-sectional image, you can also appreciate here how you already see while you are closing the device, how the breaching between the anterior and the posterior leaflet is forming, so that you have no discussion if the posterior leaflet is in or not. So in my conclusion, to speed up a little bit, and the potential future, I think our team defined the strategy, and this technology allow you to follow this strategy in all your steps, from the transeptal to going down to the mitral valve and to the grasping. So this DeviceGuide technology simplify a difficult procedure, and the device placement is very, very controlled. And I think for the future, we can even envision an auto-proctoring where because it realizes where you are and which one should be the optimal pathway that you should follow. In this case, it will tell you, please advance the system a little bit so that you go a little bit more laterally. Then you add some flex on the guide, so avoiding the aortic nudge, and then rotate a little bit posterior. So making the whole procedure, a very complex procedure, very, very simple. And I thank you for your attention.
So, Patrick, can I ask you a question? How does it change the workflow for the echocardiographer?
I think the goal of all these interventions are that things become simpler, right? And I think it's becoming more calm, because you have to do a lot less movements with your TEER probe. Once you have set your target, you don't move the TEER probe anymore, and you just let the system follow the device. And I think that's one of the big advantages. And the second thing is that really, I think this addition of the yellow dashed line that is like the artificial horizon in the plane is really brilliant. I mean, no decent pilot would actually start a plane in the midst of fog without having this system of artificial horizon, and having the fact that you know where you want to go and where you actually are. I think that really gives a lot to the discussion between the interventionalist and the echocardiographer. So that changes a lot.
So do you think it helps you communicate? Because echocardiographers understand 3D, interventionalists, it's taken me 2 decades and I'm still, at times struggle. Does it help you communicate with the interventionalist? And you can make any comments you want.
Yes, exactly. I think that's what it's all about. It needs to become simpler, right? It's straightforward. And this yellow line, apart from the green and red line, just show you how much you're off and where you have to go.
So we've been fortunate to be in the pilot program for the development. And I think just to be clear for everyone in the audience, there's echo fusion where echo, the fluoro is fused, or this is where you take the fluoro image now, instead of the other way around, you take the fluoro image and you fuse it onto the echo. And that really helps us sort of understand on the echo where we're going, trajectories. You can always see where you are. The ability also that showed that where you really hold the image and you can see the leaflets that you highlighted is a unique concept with this, because it's always in line with the device. And that's why the name is, I guess, DeviceGuide, but maybe it could be a little bit more clever, but it's good. So we're going to move on to our last speaker and then have hopefully a few minutes for more questions and anything from the audience. So Dr. Martin Swans is going to talk about his clinical experience with DeviceGuide.
Great. Thank you very much for the introduction. Great to be part of this symposium. And indeed, I'm going to talk a little bit more about using the DeviceGuide in action, so a real-life case. So I think many of the benefits of the system have been discussed already. But keeping in mind that if we're doing a mitral TEER procedure, the navigation of this procedure of the device to an anatomical target can be a complex workflow, and that requires a heart team, so an interventionist, an echocardiographer, to understand in real time the position of the device, the trajectory, but also the orientation. And displaying and interpreting these images, it needs a certain amount of expertise, but also a high level of communication. So, and I think DeviceGuide can help you because it's an automatic AI-based imaging and device tracking solution. So, what are the key features? So, as already discussed, so the workflow is completely different. So we start by looking at the anatomy of the patient. We look what the anatomy is and we determine what the strategy of the patient will be. And that's where we're going to put our target. This is where we're going to place the marker where we want to place. And then afterwards we can see this augmented device information. So we have these yellow dotted lines where we can see lines that indicate the device trajectory and the orientation, but also the model is now being created if it's in position, what the orientation is and the configuration. And then down below here on the left side, we can see an auto-aligned view, so where we can optimize see an optimized view of the device. So not to look for it, it's optimized by the software itself. So it changes the workflow. So again, we sit together up front in the procedure, we determine where we want to place our first device and in which angulation and which orientation. And then afterwards, it's a little bit difficult for in the beginning because then you have to lay down your probe as an interventional imager. So you lay down because the software does it for you, and it gives you automatically the feedback. And then you spend a little bit more time prior to the procedure because you determine where you want to go. But during the procedure, you can be very effective because simply these lines show the interventionist what maneuvers he needs to do. And I will show you a little bit. So to show you a little bit a clinical case example, this is a case with a P2 prolapse, and the first step is always inserting the device in the left atrium. And again, we want to avoid hitting the wall or anything. And with this, we can put it on device-centric mode because it now, normally it can go out of your 2D plane, but now it's completely always focused on the device, and we can see the Coumadin ridge here, we can see the aortic valve here, we can steer down without inserting or hitting the wall. And then we move on to the target mode. Again, we put the target, this is a P2 prolapse, a wide prolapse, and the first device we wanted to place is on the medial side of the P2 prolapse. So we oriented our line here in the intercommissural view, so medial lateral. We have the L view, T view, and again we can see in the intercommissural view we're quite okay. So the yellow line is more or less on top of the red line, but if you look in the red box, we can see the yellow line is definitely not on the green, our ideal path. So, and if we look, even if the device is closed, down below here, we can see a sort of short axis view. We can see even if the device is closed, the orientation is definitely not aligned with the valve yet. So we have to correct for this. And this has been done here. So there was a little bit of sort of aorta hugging. So we went away from the aorta. Now you can already see in the green box and the red box we're nicely aligned already. But here we can see the device is oriented towards 1 o'clock. Here we can see an optimized view, but we can see we have to correct for this as well. And that's been done here. So now green is okay, red is okay, and now if you look here now, we can see the yellow line is also now nicely on top of our red line here, and we have an optimized view of our leaflets and the device itself. And then, of course, we're going to cross the valve, and as already mentioned by Roberto, sometimes there is difference in orientation. Also here, if you advance the probe, you see there's a clockwise rotation towards 1 o'clock, and then in the valve, below the valve, we can correct for this because it's nicely showing, even if you can't see the device, immediately what the device orientation is. And of course, the next step will be the seating and the grasping of the leaflet. So we come up, we use for this the device-centric view. So the image, the device is optimally visualized. So we see the leaflets very nicely. Here we can see you do an independent grasping, so the anterior leaflet is being grasped here. We see the clasp going up and down, and then we swing a little bit towards the posterior leaflet. We can see the prolapsing segment over here. It's on the device now, and in a second the device will be closed. It's not completely optimal. It's going to show. Takes some time. Sometimes the interventionist, he closes, then advances a little bit more, and then being able to grasp the posterior leaflet very well. We can see the clasp going up and down, so being a decent grasp. The completely optimized images are of perfect quality. And the nice thing about this, because now I said you normally do not move the probe anymore that much, but sometimes you end up in your grasping view, indeed your device or your guide or anything is on top of the leaflet and you have some shadowing. And this is an example from Shoshil, where you nicely can see in the beginning of the movie I will start, you will see some shadowing over here, and then the probe is being pulled up a little bit, and then you see the imaging is optimized again. So important to get good results is optimizing the graph. So this is you can close the device now and be sure that the leaflets are completely inside. And then afterwards we did exactly the same with the second implant, so it doesn't interfere that you already placed the device. We oriented, we aligned the planes, we went in and then did an optimal grasp again using the device-centric mode. And then we'll end up with a big prolapse here with a significant regurgitation where we put in 2 devices with only a trace regurgitation after the procedure. So I think in summary it's the first of its kind procedure-specific imaging. It's an AI enabled and it's really a next generation. Even for experienced center, it helps a lot, I would say. It's augmented MTEER device tracking, NPR alignment, and it gives you information all the time about the position, trajectory, and orientation in real time. And I think it has a lot of impact during the procedure because it makes it efficient, the communication is more efficient, and also for the interventionist just simply knows where to go and to place the device. And I think showing you the images here will be safer and will get better outcomes because we simply see the device better. And I think it's going to be even more impactful, and that's work in progress at the moment. We're working on the tricuspid side. This is a case we recently done. Unfortunately, not imaging quality perfect. Maybe 3D eyes can help. But again, here, so on the short axis view, even without seeing the device, it can tell you the orientation of the device and we can align it with the line of cooptation. I think, especially on the tricuspid side, it has a lot of benefits. So, thank you for that.
Any questions from the audience or any comments from the panel?
Yeah, I guess there's a question from the audience about the kind of along the lines of the registration between the fluoro and the echo. How does the system know what's the device? Do you have to identify it? How long does it take? Does it add a lot of time to the procedure?
Well, probably have to ask Philips how it works. But, usually it takes 15 seconds to align with the 2 different views in the fluoro. It's just really a matter of 15, 20 seconds. That's done very fast.
Yeah, I mean, the issue is that the echo probe and the device have to be in the fluoro view. So fluoro has to be on. So that is one sort of limitation for alignment. Can I ask a question to our imagers? Does this mean that I could be the imager for Matt to do a mitral TEER? Is this going to allow me to switch roles and go to the head of the table and do the imaging?
That's never going to happen.
I think it's the other way around. I think it's the other way around. We will do the implant.
Oh, so listen, Becky always says I'm her robot. She says, go posterior. I go posterior. She goes, go in, so this is what you're going to get to, right? No, in all seriousness, part of the goal for all these technologies we talked about in the beginning was sort of democratize the procedures. Everyone here on the panel, you've done 1,000 clips or more or whatever, but there are a lot of centers where they're doing, maybe 1 clip a month, maybe 2. What is the role of technologies like this in that scenario?
I love your concept of democratize the procedure. I really think, in particular, if you are dealing with complex procedure, then you have to simplify as much as possible. And I think really imaging the role of imaging is exactly there. So providing us with systems that allow you just to follow a line. For me, as an interventioner, if I see the lines, I follow the lines. It's extremely easy. I don't have to understand how 3D echo works and so on. This is too complex for me. And that's why, honestly, I think, we have, at least in Europe, people working in structural intervention, they do a lot of structural intervention in different fields with different devices. It's not that they're doing just Pascal or just Mitra clip or so on. So that's why the experience is a big problem. And I think if we are able to provide something that is robust, that is easy, then we will do the goal. And I think in the mitral, our goal is to be as good as surgeon. So it's extremely high level to achieve. So the goal is not just to be safe in implanting some clips. It's just to have a perfect result. And I think imaging is the way to go.
Wonderful. And unless you have any other quick comments, we're sort of reaching the end. I mean, I think this we have two sort of concepts. Early on, in the first part of the session, we talked about the VeriSight 3D ICE probe and how it's going to sort of change potentially procedural workflow in the case of left atrial appendage or augment workflow and improve procedural efficiency results and maybe reduce procedure times in tricuspid TEER. And so that's exciting. That's here. That's going to be available here shortly. But the second part, we saw a little bit of a glimpse into the future, how we can use AI. And for me, this is the first time that AI, the Echo Navigator, where it was the fusion of Echo onto Flora, I never understood how it helped me. I couldn't figure it out. It really didn't change or improve my procedural workflow. But this, for me, was the one thing I was telling Matt during the talk. It's really, I can see how this is going to change things, especially on the tricuspid, the mitral, the ability to just sort of stay on and just remove the probe a little bit and get rid of shadow. That's game changing. Whereas you're spending 5 minutes to to try and get rid of a better view. Here is just stay on and come up. Those type of technologies are coming. They're going to continue to be the future, and they're going to really drive the space forward of innovation. And right now it's with Pascal, but you can see how these type of technologies can be applied to all sorts of structural interventions we do. So I think there's a lot of excitement. A lot of where this stuff is leading is going to be where things that are just to our imagination right now, but it's an exciting time for structural imaging and intervention. Thanks to the panel and thanks to all of you for joining us.